Welcome back to the deep dive. Today, we're shifting gears a bit. Instead of focusing on treating diseases that have already taken hold, we're digging into something maybe even more fundamental.
That's right. We're looking at the building blocks of health itself. How do we actually promote health and prevent problems in the first place?
And for this, we're turning to a really interesting section in Harrison's internal medicine. Usually you think of Harrison's for diagnosing, complex conditions.
Exactly, but this part flips the script. It's all about evidence-based, practical steps for health promotion. Think primordial prevention, stopping the risk factors for disease before they even start.
So our mission today is to really unpack these core lifestyle pillars that Harrison's lays out. We're talking everything from physical activity to sleep, weight, addiction avoidance.
All based on the evidence presented in the text. The goal isn't just living longer, but living healthier for longer. Harrison's actually uses this great phrase, squaring the curve.
Squaring the curve, what does that mean exactly?
It means maximizing the time you spend in good health, vibrant health, and pushing that period of illness or, morbidity right to the very end of life.
So a longer health span, not just lifespan. I like that. Okay, let's dive in. Where does Harrison suggest we start for the biggest impact?
Unsurprisingly, it starts with physical activity.
Yeah.
And the absolute foundational principle, the starting point for everyone, especially if you're sedentary now, is really simple.
Okay.
Any physical activity is better than none. Period.
That feels really liberating, actually. Takes the pressure off having to run a marathon tomorrow.
It absolutely should. If someone's doing nothing, even just 5 or 10 minutes of walking is a huge clinical win. It directly ties into this idea of a non-linear relationship between activity and health benefits.
Non-linear. So not just a straight line where more activity always equals proportionally more benefit.
Right. Think of it like a curve that shoots up really steeply at the beginning. The biggest health gains, the largest marginal benefits, happen when you go from zero activity to even low levels of moderate activity.
Wow. So that first step is where you get the most bang for your buck, health-wise.
Precisely. That initial phase shows the most dramatic reduction in things like all-cause mortality. The benefits definitely keep increasing as you do more longer duration, higher intensity, but the rate of increase slows down. It's a curvilinear increase.
Okay, that steep initial climb is powerful. The text actually quantifies that early benefit, doesn't it? Something about cardiovascular events.
It does. It suggests that achieving just that baseline of 150 minutes a week of light to moderate activity can cut the risk of major cardiovascular events by about 15%. It really highlights how impactful just getting started is.
So that makes the standard guidelines feel a bit more approachable. What are the current core recommendations for adults, say 18 to 64?
The consensus is aiming for at least 150 minutes per week of moderate intensity aerobic activity.
Okay, 150 moderate
Or if you prefer higher intensity, 75 minutes per week of vigorous intensity aerobic activity, or, some equivalent mix of the two.
And it's not just about the total weekly minutes, right? How you schedule it matters.
Yes, definitely. Spreading it out throughout the week is key. Trying to cram it all into the weekend, the sort of weekend warrior thing, isn't ideal. And ideally, the activity should happen in bouts of at least, say, 5 minutes at a time. It doesn't have to be a solid hour.
Okay, so spread it out, minimum 5-minute chunks.
Yeah.
And that's the aerobic part. What about strength?
Crucial addition. Muscle strengthening activities are recommended at least 2 days per week, and this should involve all the major muscle groups: legs, hips, back, abdomen, chest, shoulders, arms.
2 days a week, major muscle groups.
Got it.
Yeah.
Now, Harrison's throws in a really important point here that seems almost counterintuitive. It's about being sedentary.
Ah, yes. The sedentary trap. This is critical.
You can be someone who diligently gets their 150 minutes, maybe even more, but if you spend the rest of your day sitting, that's still a problem.
It's an independent risk factor. The text is very clear. Sedentary time, sitting, reclining, lying down while awake with low energy output has adverse health consequences, regardless of whether you meet those activity guidelines. So my morning run doesn't completely cancel out sitting at my desk for 10 hours.
Unfortunately, no. The mechanisms aren't fully worked out, but one leading idea involves an enzyme called lipoprotein lipase, or LPL.
LPL, what does that do?
It's really important for fat metabolism, helps clear triglycerides from your blood. Activity boosts LPL in your muscles.
Okay.
But Prolonged, uninterrupted sitting seems to suppress LPL activity. This might lead to less favorable lipid profiles, maybe contribute to insulin resistance, even if you exercised earlier.
So the sitting itself is metabolically problematic. What's the advice then? Just stand up more.
Essentially, yes. Frequent breaks, just standing up, walking around for a few minutes periodically throughout the day might help interrupt that metabolic stagnation. Break up the sitting time.
Okay, that's a practical takeaway. Let's circle back to the strength training guidelines. Any specifics on how to do it safely and effectively?
Well, for aerobic, variety is good. Biking, swimming, walking helps avoid overuse injuries, maybe boredom too.
Makes sense.
For resistance training, Harrison's emphasizes using body weight or weights that allow for more repetitions. Think maybe 3 sets of 15 to 20 reps rather than super heavy lifting for low reps.
Higher reps, moderate weight, and there was a specific warning about technique. Something about breathing.
Yes, a very important safety point, avoiding the Valsalva maneuver.
Right, the Valsalva, that's when you hold your breath and strain, right? Like during a heavy lift or even straining on the toilet.
Exactly. Forcibly exhaling against a closed airway, a closed glottis. Lots of people do it without thinking during exertion.
Why is that risky for, say, the average person starting strength training?
It causes really rapid, significant swings in blood pressure. The initial strain increases pressure inside your chest, which reduces blood flow back to the heart, dropping cardiac output. Then, when you release the breath, blood pressure can surge upwards quite dramatically.
Okay, that sounds not good, especially if someone has underlying issues.
Precisely. For anyone with hypertension, diagnosed or undiagnosed coronary artery disease, maybe fragile blood vessels in the brain, that surge can be dangerous. It could potentially trigger arrhythmias, maybe even a stroke or another cardiovascular event in susceptible individuals. So the key instruction is simple. Breathe continuously, don't hold your breath, and strain.
Crucial safety tip. Okay, let's address another common concern, maybe the biggest one for people starting out. The fear of, well, sudden cardiac death during exercise.
It's a valid concern, and Harrison's addresses it directly with data. Statistically speaking, the acute risk of sudden cardiac death does go up slightly during the act of exercising compared to being at rest.
Okay, that sounds worrying.
And this is the crucial part, that transient increase in risk is massively outweighed by the protective effects of being fit in the first place. Regular training substantially lowers your overall baseline risk.
Okay. So the fitter you get from exercising regularly, the lower your overall risk is, making that tiny increase during exercise less significant.
Exactly. The net effect is overwhelmingly positive. Your improved cardiovascular health from consistent training provides huge protection.
So the advice is not to fear exercise, but to progress smartly.
Precisely. Start gradually. Aim for those 30-minute sessions, maybe 5 times a week. Build up duration and frequency first. Then, once you have a solid base, you can think about adding things like interval training, short bursts of higher intensity, which can provide even greater fitness benefits.
But there's also a note of caution about pushing things to the extreme, right? Like marathons and triathlons.
Yes, there is. These extreme endurance events require very careful, graded training. They undeniably place a greater cumulative toll on the musculoskeletal system.
Makes sense. Lots of repetitive impact.
But there's also evidence of measurable impact on the heart muscle itself.
Really? What kind of impact?
Studies show that after these long, intense events, athletes often have elevated levels of cardiac troponin in their blood.
Troponin. Isn't that the marker doctors look for during a heart attack?
It is. It indicates some level of myocardial cell stress or damage. Now, in well-trained athletes, these elevations are generally lower and transient, likely reflecting reversible stress rather than permanent damage or necrosis like in a heart attack.
Okay, so it's a sign of extreme stress. Not necessarily a heart attack, but still a warning sign.
Exactly. It underscores the immense physiological strain these events place on the heart. It's a reminder that undertaking such challenges requires appropriate training, good underlying health, and shouldn't be taken lightly. It's not for everyone.
That's a really important distinction between healthy activity and potentially harmful extremes. Okay, let's transition now to the specific guidelines across different age groups. Before we do, can you clarify how Harrison's defines exercise intensity? You mentioned moderate and vigorous.
Sure. They use a simple subjective scale from 0 to 10 relative to someone's personal maximum capacity. 0 is sitting still. 10 is absolute flat-out maximal effort.
Okay, so where does moderate fall on that scale?
Moderate intensity is typically a 5 or 6 out of 10. It's activity that gets your heart rate and breathing up noticeably, but you could still carry on a conversation, maybe a bit breathlessly. Think brisk walking, doubles tennis, cycling on flat ground.
Got it. Working but not gasping. And vigorous.
Vigorous is usually a 7 or 8 out of 10. Your heart rate and breathing are up substantially. You wouldn't be able to say more than a few words without pausing for breath. Examples would be jogging or running, swimming laps continuously, singles tennis, cycling uphill.
Okay, 5-6 for moderate, 7-8 for vigorous. Makes sense. Let's start young. Preschoolers, ages 3 to 5. What's the recommendation there?
For this age group, it's refreshingly simple. No specific minute counts. The main goal is just for them to be physically active throughout the day. Lots of different types of active play.
Just let them run around.
Pretty much. The emphasis is on enhancing their growth and development naturally. The key message is really for the caregivers. Encourage active play, don't just park them in front of screens. Think climbing, running, dancing, jumping.
Right, fostering that natural inclination to move. Okay, moving up to school-aged kids and adolescents, ages 6 to 17, things get more structured here.
They do. This is a critical period for development, so the guidelines are more demanding. They need 60 minutes or more of moderate to vigorous physical activity every day.
An hour a day.
Wow.
And it's not just any activity, right? There are specific types needed.
Correct. That daily hour needs to include 3 specific components, each done at least 3 days a week.
Okay, what are the 3?
First, vigorous intensity aerobic activity, things that really get them breathing hard. Second, muscle strengthening activity like push-ups, climbing, or using playground equipment. And third, critically, bone strengthening activity.
Bone strengthening. Why is that singled out for this age group?
Because this is the peak time for building bone mass. Most people achieve their maximum bone density in their late teens or early 20s. So activities that put stress on the bones during these years are vital for preventing osteoporosis later in life.
What counts as bone strengthening? Things with impact.
Exactly. Impact or tension forces. So running, jumping rope, basketball, gymnastics, lifting weights, anything that loads the skeleton. Very important for long-term bone health.
Okay, hour a day with aerobic, muscle, and bone components 3 times a week. Got it. Now, we cover the 18 to 64 adults, the 150 moderate or 75 vigorous, plus 2 strength days. What about older adults, 65 and up?
The core guidelines are basically the same starting point. Aim for the 150 or 75 minutes plus strength training. However, there's a big caveat. They should be as active as their individual abilities and chronic conditions allow.
So it needs to be personalized.
Absolutely. Their level of effort has to be judged relative to their current fitness level, which can vary hugely. And they need to understand how conditions like arthritis, heart disease, or balance issues might affect what they can do safely.
And Harrison's highlights a specific type of activity that becomes especially important for this age group.
Yes, a crucial addition. Multi-component physical activity that specifically includes balance training.
Balance to prevent falls.
Precisely. Falls are a huge cause of injury, disability, and loss of independence in older adults. So activities that challenge balance, things like Tai Chi, standing on one leg, heel-toe walking, should be incorporated alongside the aerobic and strength work. It's a key intervention for maintaining function and safety.
That makes perfect sense. So across the lifespan, the focus shifts from general development to maximizing bone and fitness to maintaining function and preventing falls. Okay, physical activity is clearly foundational, but Harrison's emphasizes it's just one piece of the puzzle. Let's talk about the other interconnected lifestyle factors, starting with sleep.
Right, sleep hygiene. Often overlooked, but incredibly important. The text reinforces the consensus for adults 18 and over. The optimal range is consistently getting 7 to 9 hours of sleep per night.
7 to 9 hours. What happens when people regularly fall short of that, less than 7 hours?
The consequences are pretty stark and wide-ranging. Short sleep duration is linked to a whole host of problems: increased risk of obesity, type 2 diabetes, partly through worsened insulin sensitivity, high blood pressure, cardiovascular disease in general, depression, even increased risk of dying from any cause, all-cause mortality.
Wow. It really throws a wrench in the works systemically.
It does. It also impairs immune function, making you more susceptible to infections, and definitely impacts cognitive performance, attention, memory, decision-making.
You mentioned obesity. Is there a direct hormonal link there that clinicians should be aware of?
Yes, a very clear one. Lack of sleep messes with the hormones that regulate appetite. Ghrelin, the hormone that makes you feel hungry, goes up. Leptin, the hormone that signals fullness or satiety, goes down.
Oh, so you feel hungrier and less full. That's a bad combination for weight control.
Exactly. It's a double whammy that directly promotes calorie consumption and weight gain. It's a significant factor contributing to the obesity epidemic that often gets missed.
So conversely, getting enough sleep actually helps with other health goals.
Definitely. The text notes that adequate sleep is associated with better success in weight loss efforts, improved blood pressure control for people with hypertension, and just generally better mental health and daily functioning.
Okay. Let's talk about a specific sleep disorder that Harrison's highlights due to its prevalence and impact. Obstructive sleep apnea, OSA.
Yeah, OSA is a huge issue. The prevalence estimates mentioned are really striking, potentially 9 to 38% of the general adult population, possibly even higher now. And it's more common in men, older adults, and particularly those with a higher body mass index, or BMI.
And the consequences of untreated OSA are serious.
Very serious. The repeated pauses in breathing lead to chronic intermittent hypoxia, low oxygen levels, and surges in sympathetic nervous system activity. This significantly increases the risk of hypertension, stroke, heart failure, arrhythmias. It's a major cardiovascular risk factor.
Given how common it is, how should clinicians approach screening? What tools are available?
There are several validated screening tools. The Epworth Sleepiness Scale asks about the likelihood of dozing off in various situations. Then there's the STOP-P questionnaire. Snoring, tiredness during the day, observed apnea, someone sees them stop breathing, and high blood pressure.
SOP. Yeah.
And an expanded version, Stoppy Bang, adds BMI, age over 50, neck circumference, and gender, male, to improve the risk prediction.
Now, Harrison's points out a nuance regarding the official screening recommendations from the U.S. Preventive Services Task Force, the USPSTF. This can be a bit confusing.
It can be, and it's important to understand the distinction. The USPSTF concluded there was insufficient evidence to recommend routine screening for OSA in asymptomatic adults in the general population.
Insufficient evidence. Does that mean screening isn't useful?
Not at all. The insufficient evidence conclusion was specifically about mass screening of people without symptoms in a primary care setting. It was largely because there weren't enough studies proving a clear net benefit from screening everybody versus the potential downsides or costs in that specific context.
Okay, so it wasn't saying OSA isn't important, just that universal screening for people with no symptoms hadn't been proven beneficial yet.
Precisely. Given the incredibly high prevalence and the severe consequences of untreated OSA, clinicians absolutely should remain vigilant. If a patient presents with symptoms, excessive daytime sleepiness, loud snoring, witnessed apneas, or if they have risk factors like obesity or resistant hypertension, then targeted screening and referral for proper diagnosis, like a sleep study, is definitely warranted. The lack of universal screening mandate doesn't mean ignore the high-risk or symptomatic patients.
That's a crucial clarification. What about general tips for just improving sleep quality for everyone?
The basics are important. Getting regular physical activity, ideally earlier in the day, helps build sleep pressure. Avoiding heavy meals or excessive alcohol close to bedtime is key.
Right.
Trying to stick to a regular sleep-wake schedule, even on weekends, helps stabilize your body's internal clock, the circadian rhythm.
And what about sleep medications?
Harrison's includes a strong caution against the regular long-term use of sedative medications for insomnia.
Why is that? Because of dependence.
Dependence and tolerance are major risks, yes. But also, many sedatives alter the natural sleep architecture. They might help you fall asleep or stay asleep, but they often reduce the amount of time spent in the deeper, more restorative stages of sleep, like deep non-REM and REM sleep. So you might get more hours, but the quality isn't necessarily better.
Chemically induced sleep isn't the same as natural restorative sleep.
Yeah.
Okay. Let's move on to another huge topic, weight management.
And Harris's doesn't pull any punches here. It lays out the stark reality of the obesity epidemic in the U.S. prevalence, soaring from around 10% in 1985 to roughly 35% now, with another nearly 40% being overweight. It's a massive public health challenge.
And it's not distributed evenly across the population, is it?
No, there are significant disparities. Overweight and obesity disproportionately impact people in lower socioeconomic groups and certain racial and ethnic populations, including Black, Latino, and American Indian communities. Any approach has to consider these systemic factors.
We all know losing weight and keeping it off is incredibly difficult. So where should clinicians even start? What's the first goal?
Often, the most realistic and crucial first goal is simply weight stabilization, stopping further weight gain.
Just stopping the game.
Yes, because many of the health risks are strongly driven by continued weight gain over time. Just holding steady, preventing the number from creeping up further, is a major win and interrupts that negative trajectory. It's less daunting than aiming for massive loss right away.
Okay, stabilization first. But if weight loss is the goal, what's the fundamental principle according to Harrison's? Does the type of diet matter most? keto, low fat.
The text is very clear on this. While different diets might work for different people for adherence reasons, the underlying mechanism for weight loss is achieving a sustained negative calorie balance. You have to expend more energy than you consume.
So calories in versus calories out is still king.
Fundamentally, yes. Harrison states that weight loss depends far more on reducing total caloric intake than on the specific ratio of fat, protein, or carbs. The laws of thermodynamics apply.
But if it were just simple math, it wouldn't be so hard. Why is it so challenging physiologically?
Because the body fights back. When you cut calories and lose weight, your body undergoes metabolic adaptation. Your resting metabolic rate might decrease slightly, meaning you burn fewer calories at rest. And appetite-regulating hormones shift to make you feel hungrier. The body tries very hard to defend its previous weight set point.
The body's resistance. So tools and strategies are needed.
Absolutely. Consistency is key. The text mentions the value of things like food and activity logs, maybe using smartphone apps, to increase awareness and accountability. Experimentation to find what works for the individual. It's a partnership.
And we have to talk about the newer pharmacologic tools, especially the GLP-1 receptor agonists. They've made huge waves.
They really represent a significant leap forward. Drugs like semaglutide or tirzepatide, they work through multiple mechanisms, enhancing insulin release when needed, suppressing glucagon, slowing stomach emptying. But critically, they act on the brain to increase feelings of fullness and reduce appetite.
And the results have been pretty dramatic.
Very dramatic in many patients. We're seeing average weight loss in clinical trials reaching 15, even 20% or more of baseline body weight, which is unprecedented for medication alone. This can lead to significant improvements in related conditions like diabetes and cardiovascular risk factors, at least in the short term.
That sounds almost too good to be true. What are the caveats or challenges Harrison points out?
There are definitely significant challenges. First, access and cost are huge barriers. These medications are very expensive, and insurance coverage is inconsistent, putting them out of reach for many.
Okay, cost and access. What else?
Long-term safety data is still evolving, although generally reassuring so far. But perhaps the biggest question is sustainability. What happens when the medication is stopped? There's strong evidence suggesting that weight regain is common, likely due to those metabolic adaptations we talked about. They manage the symptoms of obesity effectively, but don't necessarily cure the underlying physiology permanently.
So they're a powerful tool, but maybe not a standalone solution forever. And this brings us back to
Physical activity, exactly. Harrison's emphasizes that once weight loss is achieved, whether through diet, medication, or surgery, increasing and maintaining physical activity levels is often absolutely crucial for preventing weight regain and maintaining that loss long term. Activity helps anchor that new, lower weight.
Okay, activity, sleep, weight. Let's tackle addiction, starting with the biggest preventable cause of death.
Smoking. Right, tobacco cessation. Harrison's identifies nicotine dependence as the critical challenge here. It's highly addictive.
And quitting is notoriously difficult. It often takes multiple attempts.
Absolutely. The text explicitly states that recidivism relapse is the rule, not the exception. Clinicians need to approach it with that understanding.
So what's the recommended approach?
It starts with assessing past quit attempts, what worked, what didn't, and importantly, gauging the patient's current readiness to try again. Then it requires persistence, frequent follow-up, positive reinforcement, offering evidence-based help like nicotine replacement therapy, patches, gum, lozenges, or medications like bupropion or varenicline.
And the key message for patients who relapse.
Keep trying. Don't view it as failure. View it as part of the process. Each attempt provides learning for the next one. Encourage them to try again.
Now, what about the newer challenge? Electronic cigarettes or vapes? Harrison's discusses their complex role.
It's a tricky one. There is some evidence suggesting e-cigarettes might help adults who are already smoking combustible cigarettes to quit if they completely switch. That's the potential harm reduction angle.
Okay, a potential tool for existing adult smokers, but
On the other hand, their use by young people, adolescents, and people who never smoked traditional cigarettes is a major public health crisis.
why is it considered such a threat for that group?
Several reasons. First, it's creating a whole new generation addicted to nicotine, often delivered in very high doses via these devices, which can harm the developing adolescent brain. Second, the appealing flavors are a huge driver of youth uptake. Third, inhaling the aerosols isn't harmless. The heating of flavoring chemicals, solvents, and contaminants can cause lung inflammation and damage. We've seen cases of severe lung injury, like EVALI, and there are long-term cardiovascular concerns, too.
So the message for non-smokers, especially kids, is unequivocal.
Absolutely. Strongly discourage initiation. The risks far outweigh any potential benefits for non-smokers.
Okay. Beyond nicotine, Harrison's also mandates screening for other substance issues.
Yes, particularly alcohol and opioids. For alcohol, the simple CAGE questionnaire is still highlighted as an effective, quick screen.
Cage. Remind us what that stands for.
Sure. Have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? Eye-opener. 2 or more yes answers suggest a potential problem needing further assessment.
Simple and effective. And opioids.
Given the ongoing opioid crisis, the text stresses the need for rapid screening tools here as well, due to the incredibly high potential for dependence and the devastating consequences. It's become a routine part of comprehensive health assessments.
Okay, we've covered the core lifestyle pillars. Now let's look at the final section in Harrison's. The clinician's overall priorities and approach in promoting health, especially during, say, a wellness visit. Where does it start?
It actually circles back to a cornerstone of public health: vaccination.
Right, reminding us not to forget the basics.
Exactly. Vaccination is framed as a major public health triumph, responsible for huge gains in longevity. The clinician's role isn't just giving the shot, but also addressing vaccine hesitancy.
Which requires more than just reciting facts.
It requires actively listening to patient concerns, understanding the root of their reluctance, and then clearly explaining the benefits individual, family, community, while honestly discussing the very low risk of rare side effects.
And Harrison's provides a key message for clinicians to use.
Yes, a powerful statement. It is true to say that no current vaccines are ever worse than the disease they prevent. It's about putting the risk in perspective.
Okay. Beyond vaccines, what other screenings are prioritized in a health promotion context?
Mental health and safety are key. Screening for depression is vital because it impacts everything else: motivation, adherence, quality of life. Similarly, screening for cognitive impairment, especially in older adults or when concerns are raised, using quick tools like the mini-cog or GPCOG is important.
That's safety.
Basic safety assessments remain crucial. Asking about seatbelt use, screening for intimate partner violence, discussing safe firearm storage if guns are in the home. And for patients identified as being at risk, assessing for suicidal ideation is a critical, potentially life-saving intervention.
Now, Harrison's makes a really interesting point about how to use the limited time available in these visits. It challenges a long-standing tradition.
It does. It questions the value of the routine, comprehensive, head-to-toe physical examination in an asymptomatic adult patient.
Really. The annual physical.
The evidence suggests that for someone without symptoms, performing the full ritualistic exam has a very low yield for detecting important treatable disease that wouldn't have been picked up through history or indicated tests. It takes up a lot of time.
So what's the suggested alternative for using that time more effectively?
The text strongly advocates for prioritizing assessment and counseling on those high-impact behavioral factors we've been discussing: physical activity, diet, sleep, smoking, alcohol, safety, mental health, things that truly affect longevity and quality of life.
So shift the focus from low-yield procedures to high-yield conversations.
Exactly. It means history-taking remains absolutely paramount. But beyond that, the crucial skills become effective communication and behavioral counseling techniques.
And Harrison specifically mentions motivational interviewing.
Yes, as a key technique. Motivational interviewing is a patient-centered approach. Instead of just telling the patient you need to lose weight or you need to quit smoking, it's about collaborating with them.
How does that work in practice?
It involves asking open-ended questions, listening reflectively, and helping the patient explore their own reasons for wanting to change, their own ambivalence about it. You elicit change talk from them, build their confidence, and help them arrive at their own commitment.
So it's about tapping into their internal motivation, rather than just giving external instructions.
Precisely. Adherence is much higher when the patient feels ownership of the plan and the motivation comes from within. Simple directives often lead to poor compliance. Eliciting patient commitments, maybe even a verbal contract, is highlighted as being much more effective.
That sounds like a more respectful and likely more effective approach.
Yeah.
Lastly, the text touches on the role of technology, wearables, apps.
It acknowledges the explosion of wearable devices and mobile health tech. These can provide lots of data on activity, sleep, heart rate, etc., offering potential for feedback and monitoring.
Good.
But the text also adds a note of caution. Having the data doesn't automatically translate into sustained behavior change. We're still figuring out how best to use principles from behavioral economics and psychology to actually leverage that data effectively. And clinicians need to be mindful of data accuracy and how to make the information clinically actionable, not just overwhelming.
So technology is a tool, but not a magic bullet. The human element, the counseling, is still key.
Absolutely. Technology can support, but it doesn't replace the need for that patient-clinician relationship and skilled communication.
This has been a fantastic deep dive. It really feels like Harrison's provides a clear, practical framework here. If we were to boil it down, what are the absolute core pillars for health promotion that emerged?
I think we can summarize it into 5 key areas based on our discussion and the text. First, regular physical activity, emphasizing that starting is key, any amount is good, and we need to counter sedentary time.
Okay, number one, move more, sit less.
Second, quality sleep, aiming for that 7 to 9 hour window and being vigilant about disorders like OSA.
Number two, prioritize sleep.
Third, caloric control and weight management, focusing on sustainable negative calorie balance, realistic goals like stabilization, and using tools like activity and potentially medication appropriately.
Three, manage energy balance.
Fourth, tobacco avoidance and addiction screening, recognizing the challenge of nicotine, the danger of new products for youth, and screening for alcohol and opioid issues.
Four, avoid tobacco and address addiction.
And fifth, mental wellness and safety screening, proactively addressing depression, cognition, and basic safety to protect quality of life.
Five, screen for mental health and safety. Move more, sleep well, manage weight, avoid addiction, stay safe, and mentally well. That really covers the foundations.
And by focusing on these, the goal of squaring the curve, living healthier for longer, and compressing that period of illness feels much more achievable. It's rooted in these consistent evidence-based actions.
It shifts the focus from just fighting fires to actually building a fire-resistant structure.
Okay, final provocative thought for our listeners. We talked a lot about that steep initial benefit curve for physical activity. The biggest gains come from going from zero to something. And we talked about the independent risk of just sitting.
So here's the question. Even if you're already meeting the aerobic guidelines, thinking about that sedentary risk, what's the one small, non-exercise activity break, just getting up and moving briefly, that you could build into your most sedentary part of the day, starting tomorrow, that might give you the next biggest marginal health gain? Something to think about.
That's a great point to ponder. It's often those small, consistent changes that add up. Thank you for joining us on this deep dive.
Thanks for guiding us through it. We'll catch you next time on The Deep Dive.